Welcome back to the Waco Family Medicine Point of Care Ultrasound Online Didactics. In this lecture, our final one in the module on MSK Ultrasound, we're going to look at the lower extremity, starting off with the hip, then moving to the knee and the ankle. This is going to be a pretty superficial, just scratching the surface of these different joints and the different things that we can see in them. But try to give you a little bit of the flavor for what you might be able to see, focusing in on some of the larger clinical things that sometimes pop up in our clinic schedules. Starting off with the hip, our probe of choice is going to be the curvilinear probe for most patients. And the reason for this is that this is a deep joint that often has lots of subcutaneous tissue and musculature overlying it. And you just need a little bit more depth penetration to adequately visualize these structures than you do for other MSK exams. The exception would be in exceptionally slim patients, or if you're looking for trochanteric bursitis specifically, you may be able to get away with using a linear probe. And then certainly for pediatric or newborn patients, if you're imaging them, a linear probe may also work. But generally, you're going to go for the curvilinear probe for most applications. Due to its deeper structure inside the body, there's really only two views that you have for your hip ultrasound views. The first is an anterior view, which is placing the probe in the direction of the femoral head, the femoral neck, as it attaches into the acetabulum and the connections with the bony pelvis. And this view allows us to see the joint capsule and the joint recess caused by the femoral neck and femoral head, which we can see here as a, let me get my pointer, the bony contour of the femoral head, and then this little joint recess with the capsule above it, and then the anterior labrum and the acetabulum sort of up here at the more superficial cephalad portion of the joint when viewed longitudinally. Then there's also a lateral view, which takes a look really at the greater trochanter, and that's really all you can see here in this view, because otherwise you're starting to get into the muscles and the softer structures in the hip. The two main questions that are asked most commonly in my clinic regarding hips are whether or not there's a hip effusion, which could be a result of an inflammatory or infectious process, or certainly could be resulting from a occult fracture that's not readily apparent. And on this view of the anterior view of the hip, using ultrasound, we can certainly see that there is a hip effusion here. So normally where this would be sort of all kind of pushed down together, there wouldn't be a large collection of anechoic fluid here. We see that there's a couple of centimeters, or about 1 centimeter of distance with this anechoic or hyperechoic fluid collection sort of in that joint recess above the femoral neck. And that is characteristic of a hip effusion. And then similarly, if we're looking at the greater trochanter, above the greater trochanter, we see this collection of anechoic fluid, and this is diagnostic for trochanteric bursitis. Now, this is not awfully something that I'm going to investigate with ultrasound, but if there's any doubt in my mind about the diagnosis, I might pull it out, and if I see this collection right over the point of tenderness on the patient's lateral hip, then I may want to make a diagnosis of trochanteric bursitis and proceed with therapy for that specifically. And really, that's all you need to know about the hip. So let's jump on to the knee. So the ultrasound of the knee is something that I do use pretty routinely in clinic, and there's some pretty cool views that you can get here, which we'll dive into in more detail. Most commonly, we're going to be using the linear probe for the knee, although every now and then in larger patients, or if you're looking at deeper structures of the popliteal fossa, you may want to utilize the curvilinear probe. Here's just a reminder of our knee anatomy. So in the anterior front view of the knee, we have the tibia inferiorly, we have the femur superiorly, and then certainly the patella with the articular cartilage of the joint space deep to these things. And you won't really see much of the articular surfaces of the knee via ultrasound because there's not a lot of sonographic windows. However, what we can evaluate are the patellas, the quadriceps tendon, the patellar tendon, the lateral collateral ligaments, and a very limited view of the menisci anteriorly. And then posteriorly, we can see the popliteal fossa, which notably includes things looking for things like Baker's cysts or popliteal cysts, and the vessels of the leg, including a DVT evaluation for the popliteal vein. There's a standardized approach to looking at the knee. In a comprehensive exam, they would recommend taking 6 views, starting off at the quadriceps tendon in both longitudinal and short axis approaches, then moving down to the patella and the patellar tendon or ligament, then taking lateral views of the collateral ligaments, and then finally moving to the posterior knee. Let's start off with our suprapatellar view. So for this view, you want the patient to be supine with their leg fully extended. You'll place the probe longitudinally over the quadriceps tendon, and you'll note that the patella will have this nice bright hyperechoic density with shadowing beneath it, and you can see the quadriceps tendon is a highly linear structure that's sort of making this triangle where it courses from the quadriceps muscle all the way up to its insertion over the patella. And then deep to that is the femur, and this is a really common view that you will definitely be looking at in your clinic, because this is how we set up our exams for a ultrasound guided injection of the knee. You can rotate your probe 90 degrees and see this in the short axis as well, although when I'm doing my exams, I usually keep it in the longitudinal view unless I'm doing an injection. And effusion is going to be seen in this space deep to the quadriceps tendon, but above the patella and above the femur here. So sort of in this little spot is where you'll see collection of anechoic fluid if there is a large effusion. Now, I mentioned here the effusion is usually seen best just laterally to the midline, and that's because sometimes the quadriceps tendon will block it. So that's just one key thing that I've picked up on. Moving on to the infrapatellar view. Once again, we want the patient to be supine with the leg extended, and the probe is going to be longitudinally placed over the patellar tendon and the tibial tuberosity. So we've just slid down on the leg, still in the longitudinal view. Here's the inferior portion of our patella and the tibia. We've got our patellar tendon or ligament right here, and then we've got a fat pad deep to that. And really what you're looking for here is patellar tendon injury, or the infrapatellar bursitis, which could be a collection of fluid right here, just deep to the patellar tendon, and could show some signs of inflammation. I've circled that for us. The medial and lateral views of the knee are important, though of low diagnostic yield in many cases. These are usually best visualized with the probe oriented longitudinally over the collateral ligaments, and you can usually see the femur and then the tibia with these highly linear structures once again coursing over these joint spaces. And here's the joint space as we see it in this view. And in this space, this is also where we see the meniscal triangle. And so you see just a little portion of the meniscus here. And it's important to note that although you can see a portion of the meniscus, ultrasound is not sensitive for meniscal injuries, especially those that cause mechanical symptoms, as those do tend to be more of the interior portions of these menisci. And so if a patient's coming in with clicking or popping or catching in their knees, remember that that can involve either of the cruciate ligaments and certainly the interior portion of the menisci. And those are patients that are going to better be evaluated with a CT or more likely an MRI to better characterize their disease. Another view that I sometimes like looking at is called the suprapatellar max flex view. For this view, you want the patient to be supine with their knee maximally flexed, so their heel kind of pulled up against their butt with their knee up in the air, and you're placing the probe transverse over the distal quad tendon. And what you see here is this sort of wave pattern of the femoral condyles. You've got a hyperechoic quad tendon right here up at the top of the screen, and then you've got this sort of anechoic area which is representing the articular surface of the joint. So this is because of the cartilage that's inside the joint. It's not that there's fluid or anything there. The cartilage is not producing lots of highly echogenic reflections. And so a lot of people will mistake this for effusion or fluid, when in reality this is likely just the cartilage overlying the bony structures of the articulating surface. This is a great view to look for arthritis and gout, and also chondrocalcinosis, which I'll show you some examples of what those look like here. So in the normal knee, in this suprapatellar max flex view, you should see the soft tissues of the muscle and tendons anteriorly in the near field. And then deeper to that, you'll see that wave of the femoral condyles, as I mentioned. And then the sort of articular cartilage will have an anechoic appearance here as demonstrated. If this line above the cartilage is much brighter than otherwise viewed on an unaffected joint in the same patient, that is a sign potentially that this patient is experiencing gout. And because of the crystal deposition that occurs on the cartilage surface, you can actually get a higher reflective index of these ultrasound waves and get a brighter line. So it sort of looks like train tracks. Sometimes they'll call it the train track sign or the river sign. But I just remember it as being a super bright line when it should just sort of kind of fade to this anechoic component and then have the bone underneath. Meanwhile, in pseudogout or chondrocalcinosis, what you'll see is that inside that anechoic wave, you get these little micro calcifications, or sometimes you look like there's almost 3 lines that are appearing. And that's because with chondrocalcinosis, you get calcifications within the cartilage itself. And that's what's causing the arthropathy and the pain in these patients. And so the appearance that you see here can help differentiate between a normal knee, a gouty knee, and a pseudogouty knee. Now, obviously, aspiration and crystal visualization is going to be the gold standard for making these diagnoses, but I think it is important to remember. Our last view of the knee involves the posterior transverse views. So for this view, you want the patient to be prone, laying on their belly with the knee extended. And where you'll place the probe is transverse over the medial-posterior popliteal fossa. Now, there are other structures in the posterior knee, so if you're looking at the popliteal veins for a DVT, if you're trying to look for other deeper structures, you may kind of move the probe a little bit to look at those. But with regards to MSK findings, generally we're looking at, when we look at the back of the knee, is identifying whether or not there is a Baker's cyst. And to do that, you need to be able to identify the medial head of the gastroc muscle and the semimembranosus tendon. And the reason for that is there's several things that can appear to be cystic structures in the knee. It could be a knee effusion that's sort of tracing posteriorly, or more commonly, it could be just big vessels or lymph nodes in the back of the knee. And so if you're really trying to evaluate if there's a Baker's cyst, you have to identify these 2 structures, because if there's fluid that's connecting that passes between the medial head of the gastroc and the semimembranosus tendon, that's the classic view you need to diagnose a Baker's cyst. And I've got a picture of that on the next slide. Sometimes it can be hard to differentiate these structures. So sometimes what I'll do is I'll start off lower in the leg, like over the gastroc, the calf, and then translate my probe in that transverse orientation, more cephalad or more proximally along the leg, until I can differentiate between the medial head of the gastroc and then that semimembranosus tendon sort of coming and abutting it. And here's an example of a Baker's cyst in the transverse view on the left and the longitudinal view on the right. So we have our medial head of the gastroc over here on the left side. Let me get my pointer out. Medial head of the gastroc. This is our semimembranosus tendon. And then we see this collection of fluid that courses between these 2 structures, and that is diagnostic of a Baker's cyst. Then we move to longitudinal view. We see sort of this collection in 2 separate planes with these structures kind of interrupting them. But this classic transverse view, that's what you need to diagnose a Baker's cyst. Next, let's move along to point-of-care ultrasound use for the ankle. A comprehensive view of the ankle involves several different imaging planes. Firstly, anteriorly, and then looking along the medial aspect, the lateral aspect, the posterior aspect, and then the plantar aponeurosis. And this is pretty complex. I'm going to show you some pictures of this on the next slide, but just know that the ankle is a really difficult structure to evaluate, and takes a lot of extra training and lots of extra practice to really hone in on specific clinical entities. So if you find this to be a challenge at first, don't worry, this is an advanced skill. So here are some of the classic views that we should expect you to get if you're doing a comprehensive ankle exam. Lots of architecture and mechanics to remember, and mastery of ankle pocus, like I mentioned, is beyond the scope of this lecture. What I do want to go over is some of the major and common pathology to sort of help you differentiate between some of those things. First of all, you need to be able to identify septic arthritis. And so if you're looking over some of these bony structures, you're seeing a collection of hypoechoic fluid, and you apply pressure and you're seeing that abscessy, sort of swirly, dishwashery sign. That is concerning that there is a infection that's involving the joint spaces, particularly a suppurative infection. And so this is what septic arthritis could look like when examining the left ankle. Another important condition I want you to know about and should be able to identify is if there's Achilles tendinopathy. So the Achilles tendon is pretty easy to identify based on its location. And what you might notice here is that the tendon is thin here, thin over here, and then sort of widens to take on this sort of fusiform structure. And at this area of widening, we also see that it's more hypoechoic relative to the other structures. And so this is a sign of some Achilles tendinitis or Achilles tendinosis. One thing that's important for the Achilles is that there is not a tendon sheath. So this is not a tenosynovitis. There's not going to be a collection of fluid around the tendon. What you're going to see is hypoechoic irregularities of the tendon itself. And so that's an important thing to remember. And if patients are having posterior ankle or heel pain, this is a pretty easy diagnosis to make with your ultrasound, because you can throw it on and pretty readily see if there's thickening and hypoechoic defects, which would support the diagnosis of an Achilles tendinopathy. Now, a rare clinical entity, but one that is important to be able to pick up on, is if the Achilles tendon ruptures. So, classically we think of this in traumatic injuries, although there are some people out there that have made associations with Achilles rupture and fluoroquinolone use and antibiotics. But what you'll see if there's an Achilles rupture is, of course, loss of the normal function of the Achilles tendon and a weakness of the ankle on your foot exam. But then you can also see a disruption of the tendon, and here we also have a developing hematoma in the area where this tendon is disrupted. And so this is a good example of an Achilles rupture. I've never seen one of these myself on ultrasound. I've diagnosed it once in clinic, or I think once when I was in medical school, actually. But it is something that's not subtle on your physical exam, and certainly not on ultrasound. Another very common clinical entity that we encounter in our clinic is plantar fasciitis. And while once again, you don't need ultrasound to help make that diagnosis, it can support it in cases where the presentation is a little bit less typical. Plantar fasciitis is involving the plantar aponeurosis as it attaches to the calcaneus, which is seen here as this hyperechoic line with posterior shadowing. And when we compare this patient's asymptomatic side to their symptomatic side, we see that aponeurosis is thickened. And so you should always compare to the asymptomatic side. But when we compare both sides, we see that this one's thicker, it's more hypoechoic, and a width greater than 4.5 millimeters is consistent with the diagnosis. And so we see that on the left side, that isn't bothering this patient. They're measuring 3 millimeters, versus on the symptomatic side, it's thickened up to 7.5 millimeters. And so this is a way that you can quantify the diagnosis of plantar fasciitis if you're looking to do so with ultrasound. And then our final clinical entity that I do want you to know about in the foot and ankle is Morton's neuroma. So Morton's neuroma is classically described as a round or ovoid hypoechoic lesion on ultrasound that exists in the interdigital spaces proximal to the metatarsal heads. Most commonly, this is found in the third web space, but it can be in other spaces. And one of the things that's kind of cool with ultrasound is that you may get a sonographic Mulder sign. So if you think about like looking at the gallbladder and we have the sonographic Murphy sign, that's pretty similar. If you apply pressure with your ultrasound probe and you feel a click or elicit your patient's painful symptoms, as you apply pressure over this area, that is a positive sonographic Mulder sign. Larger lesions, those that are greater than 0.5 centimeter in diameter, are much more likely to be symptomatic than patients that have smaller lesions. And the management of this, I expect you all to know, and we won't go into in detail during this lecture. So that's a summary of our point of care ultrasound for MSK. Once again, like I have mentioned multiple times in this module, this is a introductory course to MSK ultrasound, and certainly in our POCUS clinic or in your MSK clinics or your continuity clinics, you may discover other uses, and I would encourage you to do so. But this is sort of the taster sampler platter of the different ways that you can utilize. The big takeaways for this module are being able to recognize when a structure is inflamed with those initial signs of thickening or hypoechoic collections of fluid and hypervascularity. Those are applicable to any muscle, any tendon that you're going to be identifying. And then being able to differentiate structures that are normal versus abnormal. So being able to find a nerve and isolate it from surrounding structures, being able to see a bone and isolate it from surrounding structures, being able to identify when something is present that shouldn't be there, like a foreign body. Those are the essential skills. Knowing all of the different tendons and stuff is not something that I expect you to know, but I do want you to be able to identify what you're looking at as a, maybe not the specific tendon, but at least as a tendon or as a muscle or as a bone. And be able to use that to guide your decision making when dealing with all of the myriad, thousands of different musculoskeletal complaints that present to our clinic system every single day. Thanks for listening to this module, and we'll be back soon with more ultrasound uses in primary care.